Okay, everyone. I know some people are still getting food, but let's go ahead and get started. So for those of you who don't know me, I'm Maggie Nelson. I'm a second-year resident, and I prepared this presentation with Dr. Jaimes and also got some help from Dr. Reynolds. So I'd like to give a special thanks to her as well. And our presentation is called Mental Health Conditions and Hyperthyroidism. Although this is not a case of the week, this was kind of inspired by a patient that many of you residents might be familiar with that we've treated on the floor who has both of these issues. Okay, so our objectives are to formulate a specific clinical question about our study design, which will look at exposure and outcome, to understand the pros and cons of a cross-sectional study, which is what we'll be looking at, to talk about things such as confounding factors, prevalence, and correlation, and then, like in any journal club, to assess the internal validity as well as the external validity of our article. And Dr. Jaimes and I want to make this interactive. So you don't have to do it yet, but so you know, we'll be splitting into groups, and one group will discuss cross-sectional studies, one will talk about the internal validity of this study, and one will talk about the external validity. So just prepare yourselves. Okay, so let's move on to our clinical question using the PICO format. So our population in this study is children beneficiaries in the military health system. The exposure is to hyperthyroidism. Our comparison is just the general population. And our outcomes are a variety of mental health conditions. So this is a question basically based on prevalence of both hyperthyroidism and mental health conditions, and then the possible correlation or association between the two. And the type of study is a cross-sectional study. The article is taken from a recent issue of Pediatric, the November 2019 issue, so some of you guys may be familiar with it, and it's called Mental Health Conditions and Hyperthyroidism. Okay, just to give you a little bit of background info, stuff that you probably already know, Graves' disease is the most common cause of hyperthyroidism by far in children. The incidence is about 0.9 per 100,000 children, and about 3 in every 100,000 adolescents will be diagnosed with this per year. And then the prevalence overall of children in the U.S. that have hyperthyroidism, Graves specifically, is 1 in every 10,000 children. Common symptoms of hyperthyroidism include tachycardia, weight loss, tremor, breathlessness, heat intolerance, et cetera. And it's very important to try to get an early and accurate diagnosis of hyperthyroidism because there is a rare but potentially life-threatening side effect, which is thyroid storm or thyrotoxicosis. So what does this have to do with mental health? A lot of psychiatric illnesses present with similar symptoms to what we just talked about. It may be a little hard to see this table, but I pulled this from another study that basically looks at the cross-section of hyperthyroidism symptoms and anxiety, mania, depression. They may also have nervousness, fatigue, weakness, anger, difficulty concentrating. So you can see how it'd be difficult to parse out these two different issues. So given this overlap between these two types of pathologies, it's not uncommon for, and it's been elucidated in different case studies, these two situations. So children to be diagnosed with or treated for ADHD or anxiety prior to a later diagnosis of hyperthyroidism, which may have been contributing to their symptoms, and then also mental health conditions that persist beyond a control of clinical hyperthyroidism. So then the patients later get treatment for their mental health condition because earlier on just the hyperthyroidism was addressed. So what's currently in the literature about kind of the overlap between these two diseases? American Thyroid Association's guidelines, they have great comprehensive guidelines on the treatment of hyperthyroidism and Graves' disease, specifically that addresses many organ systems, but there's no mention or guideline on mental health care for these patients specifically. And then we have a lot of case studies out there about patients who have hyperthyroidism and also concomitant mental health disorders such as psychotic breaks or suicidality. But these are just case studies. Some of them show that mental health symptoms improve with hyperthyroid treatment, some don't. And then there's a limited number of large-scale studies assessing any sort of association between these two conditions. So what is a cross-sectional study? We'll all kind of rewind to the beginning of medical school here and see if we can remember. So you take a look at your study population, and then you have cases and controls, so people who have a certain disease or condition and people who don't. And then you look at whether they were exposed to something or whether they were not. So, for example, if you have people who have lung cancer and people who don't have lung cancer in a general population, how many of those people in each of those groups smoked and how many didn't? So to give you a brief recap of our study design, our researchers looked at children between the ages of 10 and 18 in the military health system who were beneficiaries of that system. They then looked at children who had a hyperthyroidism diagnosis and children who did not carry that diagnosis and looked at the prevalence. And then they split that into children who had a mental health condition diagnosis and those who didn't within those groups. So they looked at a prevalence ratio, which is of the children who have hyperthyroidism, are mental health conditions more prevalent within that group of people compared to just the general population? Who were the participants? Basically, they just did chart reviews, so they looked at the military data requisition system, which is basically kind of like their EMR, and they looked at children aged 10 to 18 years old who were beneficiaries of that system. They examined through fiscal years 2008 through 2016, and that encompassed about 2.5 million children. It's a pretty big group. The exclusion criteria were pretty simple. So basically, they threw out people if they were covered for less than 1 month's time because they felt like that would just be transient and they wouldn't be able to have a full picture of what that child's health care actually was like. Regarding screening and patient selection, so patients were identified through this data repository system, and they used ICD-9 and ICD-10 codes for hyperthyroidism as well as multiple mental health conditions. And they only included patients in this study if they carried this diagnosis from at least 2 or more outpatient visits or 1 or more inpatient hospitalization, just in case maybe at one outpatient visit someone had thrown depression on a chart and then it had never come back up. They didn't really trust that as a real diagnosis that that child carried and was treated for. If patients carried multiple diagnoses, for example, anxiety and ADHD, they were included in both of those categories. And then they gave each patient a unique identifier that they used for their study. Okay, so what were the primary endpoints of this study? They looked at just prevalence of hyperthyroidism in the military health services population, and they looked at prevalence of multiple mental health conditions in the same population. They then looked at prevalence of the mental health condition diagnosis in children diagnosed with hyperthyroidism as compared to the general population, basically creating a prevalence ratio. Some secondary endpoints that the article also looked at were prevalence in hyperthyroidism in varying sexes and ages, just kind of getting an idea of the epidemiology, and they also assessed timing of the mental health condition diagnosis as compared to the hyperthyroidism diagnosis, just to kind of see which came first. They also assessed whether sex was an effect modifier on the likelihood of having a mental health condition while carrying the diagnosis of hyperthyroidism to see if there was a significant difference between sexes. Okay, so the study procedure, talked about most of this, we're just putting it all together. So first they collected data, looked at their EMR in these specific fiscal years, screened for the ICD-9 and 10 codes for children with hyperthyroidism and mental health conditions, narrowed that down to patients who carried that 2+ times the outpatient setting or 1+ times the inpatient setting, gave them an identifier number, and then they analyzed their data, looking at prevalence of hyperthyroidism and prevalence of mental health conditions stratified by age and sex, and then the prevalence ratio for mental health conditions in patients exposed to hyperthyroidism, and also looked at the timing of that mental health condition diagnosis. So the statistical analysis is pretty simple in a cross-sectional study. They look at prevalence, they look at this prevalence ratio, which is looking at whether those with hyperthyroidism have a higher prevalence of a mental health condition compared to the general population. And then they assessed for effect modification, so looked at sex to see if there was a modification on the effect, a modification on the prevalence ratio, if one gender was more likely to have a mental health condition with hyperthyroidism than another. They also did some fancy statistical things, so looked for confounding using the Mantle-Hensel adjusted prevalence ratio, which I know we all use daily. And they had alpha equals 0.05 to assess for statistical significance, pretty standard. So what are prevalence ratios? So a little bit of biostats here. It's very similar to the odds ratio, which we all had to memorize for step 1. So it's looking at those who were exposed, how many had the disease, and of those who weren't exposed, how many had the disease, and they're creating a ratio between those two things. Looks at whether exposure alters the prevalence of a certain disease. So if your prevalence ratio along with your confidence interval is greater than 1, then exposure to something, in this case hyperthyroidism, is associated with a significantly increased prevalence of the disease. And if it's less than 1, then it's associated with a significantly decreased prevalence of the disease. Okay, and then just to quickly talk about the primary endpoints in the study before we dive into all of our analysis. What they found was that overall prevalence ratio-wise, that those with hyperthyroidism were more likely to have multiple types of mental health conditions, including adjustment disorder, anxiety, ADHD, bipolar disorder, depression, suicidal ideation, and action. They found that certain mental health conditions, those that have the little A by them, did have an effect modification of sex, and in those, the males had an even higher prevalence ratio than the females to have those mental health conditions. And as you see, all the confidence intervals are also greater than 1. Okay, so that was a quick kind of cliff notes of the article, and now we're going to critically appraise it together. So I'd like to split up into 3 groups. All right, let's circle back. Thank you for your lively discussion, everyone. I appreciate it. So I know you're all dying to tell me what you think, and every group will have their turn, okay? So first, let's start by talking about cross-sectional studies. Just to remind everybody what a cross-sectional study is, I'm going to briefly review it, and then we'll hear Group 1's thoughts about the pros and cons. So I'm sure everybody remembers this lovely pyramid, which kind of sorts different types of studies. So the studies that have the lowest quality of evidence and the highest risk of bias are going to be at the bottom of the pyramid, and as you go up the pyramid, you get better quality of evidence and less risk of bias, ending with our beloved randomized controlled trials and systematic reviews. So where does my little cross-sectional study lay in this? Kind of in the middle. So it's an observational study. It analyzes data from a specific population at a specific moment in time, kind of like a snapshot. And it determines whether this exposed population has a higher prevalence of one or more diseases or disorders. But it doesn't really establish any sort of causation because it's just looking at one moment in time. It can be used to estimate basically the burden of a disease in a population and kind of determine priority of different diseases by examining them at the same time. So what are the pros and cons, Group 1, of cross-sectional studies that you guys thought of? No, I just was describing the study. Just interpret what I said, you know?
You interpreted what we said.
Okay, well, just give me some ideas. You got this.
Pros are that you can get a lot of people at one time.
Okay.
Accomplish some experimental studies.
Say that, Dr. Wachowski. So it could be a large group that's kind of easy. It's an easier study to perform, yeah, right? Because it's kind of mostly chart review. Okay. Any cons to cross-sectional studies? Looking at kind of like one moment in time. Okay. Anything else? Causation is hard to determine. Yeah, someone's paying attention. What about, do you feel like it's easy or hard to account for confounding factors in a cross-sectional study? Hard, yes, Vaish. Because you're not like controlling for a lot of these factors or variables like you might in a randomized controlled trial. Any other thoughts?
About how this study kind of seems like a combination of a cross-sectional and a case control, like a retrospective case control.
Yeah. Yes. I think technically it's kind of like it's a cross-sectional, but Dr. Jaimes and I were debating that as well, kind of whether case control versus cross-sectional, but because it's mostly just chart review and you're kind of just throwing out a net for ICD-9s and 10s. That's, I think, where it lands mostly, but there's a little bit of overlap there for sure. Anyways, the timing is interesting because some patients you may catch at the beginning of the study and some you may catch at the end, so there's no defined time period that you're following the patients for, and I think that's where it kind of varies from the case control. Okay, so just to reiterate what Group 1 already said, so it's just a snapshot in time. They did try to look at timing of mental health condition diagnosis in this study, but I don't think it really helped as far as really assessing temporality. They often use kind of these large and convenient samples instead of a truly randomized population, and it's very difficult to control for confounding factors. Also can be unhelpful for some rare diseases that may have a smaller N, even in a large population. So those would be diseases that you would need to study via a trial where you're basically recruiting specifically people with that disease. And then there are some pros. So they are relatively easy and inexpensive to perform, just like you guys were saying. You can look at multiple exposures or multiple diseases at one time. So, for example, in this study, they looked at multiple mental health conditions. And you can kind of get around some ethical issues that an RCT might have. So, for example, you wouldn't want to ask people to smoke to see if they have more lung cancer. You would want to look at people with lung cancer and see whether they had smoked or not. And they also are able to look at these larger populations. So there have been some situations where a drug that passes an RCT through drug trials, a rare but potentially lethal side effect such as blood clots could be found by a cross-sectional study because you're looking at a larger group of people. Then finally, I think they're helpful for kind of finding associations and then laying the groundwork for more intensive studies as you move up the pyramid, as you might say. Okay, so let's move on to internal validity. So group 2, which I think was in the back, what did you guys think as far as confounding variables or, what the internal validity was for this study? And I'll try not to steal anyone's thunder this time.
One thing we were talking about was medication. So that's not controlled for both treatment of for hyperthyroidism, whether you were treated with like methimazole or whatever versus surgery versus these bipolar disorder being treated with lithium. I'm not as familiar with side effects of all of these medications, but I'm sure that some treatments of hyperthyroidism might be associated with some higher instances of mental health.
Yes. So for anyone listening, Rachel was saying that medications weren't taken into effect. So whether patients were on medications that may affect the thyroid or medications that may affect mental health symptoms. And I think that's a really good point and something that I was thinking about as well with this paper. So very good point as far as confounding factors go. Anything else that you guys thought of?
The population has so many military families. That could have an effect on different diagnoses or prevalence of certain mental health conditions.
Yes. So Andrew was saying that, because this is military families, we're not exactly sure how that may affect that population and how they may be different from ours. You're kind of creeping into the external validity zone there as far as it being similar to our population, but I'll allow it. I just don't want group 3 to get mad. Okay, so all good points. Let's talk a little bit about assessing the internal validity of this study. So were the exposure and outcome accurately assessed to minimize bias? I could say yes, but no. So this study used ICD-9 and 10 codes, which are pretty objective. However, they rely on us to be objective in making a diagnosis and also to be accurate. So relying on us to make a diagnosis and also to make it in a timely manner. So, of course, just leaves room for error for us to not do those things. This was somewhat accounted for by this need for at least 2 patient diagnoses codes of the same condition. For example, if we were, wrongly giving someone a diagnosis, but we also may miss a diagnosis on the other side of the coin. So leaves room for human error. And then were all participants equally assessed? I said no because I did not like that the study examined multiple fiscal years of data and would determine whether a patient exposed to hyperthyroidism then had a mental health condition, because what if you jumped onto the study in 2008, you have 8 years to develop a mental health condition which will be captured by the study. But if you don't get your diagnosis of hyperthyroidism or mental health condition until 2015, or when did it end, till the end of the study, then you don't have as much follow-up time. So in that way, I don't think that participants were equally assessed over time. Okay, so were opportunities for bias and confounding identified and minimized? We were talking about this with group 2. So some opportunities, yes, I think. Others, no, although a lot were addressed in the discussion to give them credit. So the researchers assessed for sex as a modifying factor and did stratify those results, but there were opportunities for a lot of other confounding factors that were not addressed in the analysis. Of course, that's kind of what happens in a cross-sectional study, so you just have to take it with a grain of salt. So I have a lot to say about drugs part 1, and so did Rachel, right? So pharmacologic regimens for patients were not assessed. So there's a lot of treatments for mental health conditions that can have effect on the thyroid axis. For example, lithium. A lot of these are hypothyroid effects, but sometimes there can be hyperthyroid effects. So could you be treated for a mental health condition and have masked hyperthyroidism due to hypothyroid effects? Could you be diagnosed with hyperthyroidism earlier than the general population because you're getting tests more frequently because you're on lithium? Or could you even have iatrogenic hyperthyroidism? Okay, I have a lot to say about drugs part 2. Is patients treated for thyrotoxicosis are given steroids, which then may trigger or exacerbate a mental health condition. Even something like psychosis can be triggered or exacerbated by steroids. And there also is no control for patient compliance and medication status. So it's difficult to know if these patients had clinically uncontrolled hyperthyroidism and a bunch of mental health condition symptoms, or if they were clinically controlled and still were having persistent mental health symptoms. Okay, there's not a part 3. So another confounding factor is comorbidities. As many of us know, autoimmune diseases run together. So approximately 10% of patients with Graves' disease also have another type of autoimmune disease, and that alone can be depressing or anxiety-inducing, just having multiple medical comorbidities. So that's something that's very difficult to control for, and of course wasn't controlled for in this study. Then finally, there's ascertainment bias. So I really like this graphic where you go to a dog show and then you ask people if they prefer cats or dogs. So I think it's a good example of, I prefer dogs, but of ascertainment bias. So this is basically when data for a study is collected so that your members of your target population are less likely to be included in the final results. So your target population is not representing the general population if that's what you meant to represent. So your study sample is different from your target population. So the question here is, are patients with hyperthyroidism receiving more medical care and therefore more likely to be screened for mental health conditions? And on the other hand, those with mental health conditions, are those more likely to be screened for hyperthyroidism? Maybe because they're on a medication, or maybe just because you're trying to explain the symptoms that they're presenting with. Okay. So moving on to the results of the study, I know there's a lot of numbers here to look at, so I tried to narrow it down for you. So table 3 is looking at just prevalence of hyperthyroidism. They had a very large N in this study, which was great. So they were able to identify 2,480 children with hyperthyroidism, making their prevalence 0.95, similar to the prevalence in the general population. And then they also looked at just prevalence of mental health conditions in their population, and you can see those percentages here. Most were more common in the female sex. Okay, and then these are the prevalence ratios that we looked at briefly before. So this was kind of the meat of their study. The prevalence ratios of people with hyperthyroidism, their prevalence ratio of having mental health conditions when compared to the general population. So they found that the prevalence ratio for across genders and also for each gender was greater than 1, and that also their confidence intervals were greater than 1. So they argued that this showed that there was an increased association of mental health conditions with those who were diagnosed with hyperthyroidism. And then we briefly talked about this already, but those with the asterisks are those where there was an effect modification, and in each of those cases, males had a higher prevalence ratio significantly than females. And then this is the timing table. I'm not exactly sure what to make of this because 90 days is not really that much time, and that can be how long it takes to get into a therapist. But they looked at the mental health condition diagnosis as compared to the hyperthyroidism diagnosis. And this is the first column is showing you the percentage that had that mental health condition diagnosis over 90 days before the hyperthyroidism, and then within 90 days to the right, and then over 90 days after the hyperthyroidism diagnosis to the far right. So they found that in most cases, the most likely situation was that they had the mental health condition diagnosis and then the hyperthyroidism diagnosis. Okay, so how precise were the results? Statistically significant but not overwhelmingly precise is my interpretation. Our confidence intervals do range in size from about 0.7 to 4.1. And how strong is the association between the exposure and the outcome? I did find the association with hyperthyroidism was found to be statistically significant in all mental health conditions studied, but of course it's impossible to account for all of the confounding factors that we already addressed. Okay, so it's finally group 3's time to shine. Will these results help me in caring for my patients, which is external validity? So what were your thoughts, group 3?
We did talk about what Andrew mentioned, that there may be higher prevalence of mental health conditions in the military population because of the deployment and the multiple moves and all those stressors. We also talked about in the military population, maybe excluding folks who are illegal immigrants or who are, and that population is guaranteed to have health insurance and be of a certain socioeconomic status. So it's not representative of our greater population as a whole.
Yeah.
Better follow-up in military families because you get ordered to go to the doctor.
Got to follow orders. Yes, so what Dr. Doherty and Dr. Reynolds were saying is this population, the military population, representative of our population? So there's a lot of differences, some kind of negative and some positive. So they are insured, and they have at least one caregiver who's in the military who's present. But then also there's higher risks of mental health issues or substance abuse in the family. They may have a parental separation or loss. So all of those are kind of things that make this a unique population, which is different from the general. Any other thoughts about external validity before we move on?
Dr. Reynolds was commenting that in this study there were almost 4 times as many females as males who had hyperthyroidism, and that is relevant for the general population as well.
Yes, definitely. So females were definitely more likely to have hyperthyroidism, which is representative of, general population, and just females more likely to have autoimmune diseases as well. So that's a good point. Okay. So, perfect segue. So were these studies patients similar to patients in my practice in the general population? This is a recent chart that I was able to get from GoArmy.com, which talks about the racial, I didn't sign up, but the racial makeup of the Army, which is relatively diverse. But this population is inherently different from our population and kind of inherently unique. So some things that I could think of is these children are actively insured. They are under the care of at least one legal guardian who is somehow a beneficiary of the military. They are probably at a low middle class or higher SES because they are employed, and they have to be U.S. citizens or legal residents. So it's not the refugee population or the asylum seeker population. And then these children, on the other hand, also have various other stressors due to the parents' military service. So they may be dealing with a separation or death. PTSD is higher prevalence in this population as far as their parents, and substance use disorders are also at a higher prevalence in adults in the military as well.
That table's Army, right? But
this is just the Army. I wasn't able to do, yes, I wasn't able to get GoMilitary.com. I just signed up for the Army, so maybe next study. So is this exposure similar to what might occur in my patients? I think yes. Hyperthyroidism is not hugely uncommon. We see it. And then certainly mental health conditions we deal with every day, even in just a general pediatric population. And general pediatricians are often initiating or at least screening for hyperthyroidism, ADHD, depression, anxiety. A lot of times they're starting the workup and the treatment for the mental health conditions as well, at least. And does this fit with other available evidence? I would say yes. It also adds to the body of literature, in my opinion. Previously, this subject was pretty much covered by case reports that looked at patients who had hyperthyroidism and also had mental health conditions. This is more of a larger scale study. It's not perfect, but it does cover a larger population and establishes a possible association between these two conditions. There's also this kind of attempt to establish temporality in the diagnoses of these two disorders, but I think, we would need more sophisticated studies to draw any sort of causation conclusions. And what are the implications for my practice? I think that any possible risk factor that might be associated with a significantly higher of a mental health condition, especially, suicidality, should definitely be taken seriously, even though the study wasn't perfect. So there's definitely a lot of more work required to decrease confounding factors and assess this more. But you may consider some basic things. So some things that I was thinking about as far as changing my practice, if we're not already doing this, is screening patients that you're already working up for a mental health condition for a TSH. For example, someone coming in that you're assessing for ADHD. And you may screen patients with hyperthyroid symptoms or diagnose hyperthyroidism a little bit more carefully to make sure that you're assessing them for mental health conditions as well. So making sure that you're screening them for depression, anxiety. And then, kind of choosing whether you'd like to deal with the patient that has both hyperthyroid symptoms and psychiatric symptoms and get those workups started at the same time. Some people will maybe try to label this as hyperthyroidism and address that first before also getting the patient mental health care. But it might be more important to kind of pursue a concurrent workup. Will this affect guidelines? I don't think it's, there's enough data to really affect guidelines yet. But as I stated earlier, the American Thyroid Association doesn't have current mental health guidelines, and there's sometimes an idea in mental health that you kind of want to rule out possible medical causes of mental health symptoms prior to initiating treatment if the symptoms are mild. So you would do a lot of screening for TSH, et cetera, before starting mental health diagnosis and treatment. But my thought is this is pretty preliminary to initiate a change in guidelines, but you might change personal practice and try to pursue more of a concurrent workup and make sure you're screening these patients appropriately. So as far as my conclusions, before I get to questions, this is a large-scale observational study. It establishes this possible association between hyperthyroidism and multiple mental health conditions. Definitely further studies are needed to establish any sort of possible causality and also decrease confounding factors and follow these patients better over time. But I do think it lays kind of an interesting groundwork for studies to come that might and may provide a little bit of data that's at least convincing enough for us to treat these patients a little bit more carefully or make sure that we're screening both patients with mental health conditions and patients with hyperthyroidism effectively to make sure we're treating them on all fronts. Here are my references, and I'm available for any questions. Dr. Finkler?
So my question is for these prevalence ratios, I'd have to remind myself of the statistical stuff, but essentially, when you're dealing with incidence and prevalence, the lower the prevalence, the higher the ratio can be, yet not necessarily have as big of an effect, right? And so the two categories that have the highest PR are the ones that have the lowest prevalence to begin with. And so is there a bias? So if you look at something very common like ADHD,
right,
and you look for the effect size, you get a relatively low prevalence ratio of an increased risk. But then if you look at SI, for instance, with a lot lower end, same thing for bipolar, and now these PR ratios are almost 5 times.
Right.
And is that statistically? I agree, it's statistically significant, but
is it biased? But let me just pull up how the prevalence ratio is calculated. I have it up here. Okay. There. Okay. So you're saying that if you have a lower prevalence in general, then your prevalence ratio may be kind of skewed higher?
Yeah.
Okay, yes. I agree.
I don't know. So I'm just trying to think of it.
Talking about like table 5.
Yeah, I'm comparing table 4 and table 5, and the PR effect size, if you want to call it that, is a lot higher in those that have a lower prevalence to begin with. And I'm just wondering, is it a similar concept to the idea of relative versus absolute risk? So if you have something that is very uncommon, and you have a massive increase in relative risk, the actual risk may be going up from 0.1% to 0.2%.
I see what you're saying.
The population that is not that clinically significant.
Yeah.
And I'm asking, is it a comparable effect that happens here in these statistics, where a low prevalence entity looks like you have this huge increase of risk, but in reality that's just the way that the math works out when you're dealing with 30,000 out of 2.5 million people.
I think you're right, because if you just think about how the math works, then I think still the trend would hold, but it might inflate the number. Yeah, because I know about the phenomenon you're talking about as far as relative risk. So, yeah, I think that's important to take into account.
But they still are doing a reference to the general population. So they are still reference to the rest of the people they cross-sectionally gathered. They're comparing still with the general population, and that risk is higher.
Right. No, I agree it's higher. I just wondered, you know what I mean? Like I could see where you could take some of this data and write a news article that would make it look like hyperthyroidism is causing, if you have hyperthyroidism, you're going to commit suicide. You're 5 times.
5 times more likely, yeah.
I could just see where people can take information like this and potentially misrepresent.
Yeah.
And I want to make sure, when I read something like this, we do to think about what this actually means. And my statistical background is not powered enough to be able to make this determination.
I'm learning. No, I think you're right. I mean, it's like if you go from 0.1% to 0.2%, you could say that you're increasing by 100%, but it's still a very small prevalence, right? So that makes sense. And I agree. I think that, and because there's a smaller N, you kind of have to take that more with a grain of salt, too. So I think that the data is solid and that it is increasing, but it could be kind of a conflated or inflated prevalence ratio number.
But the conclusion you're making is right. That's what they mean. It's increasing the frequency in 5 times. So in theory, you're saying the risk is increasing in 5 times, but you have to be careful how you say that. But that's exactly the conclusion. The conclusion is that if you have hyperthyroidism, they are suggesting that conclusion. You're going to have a 5 times more risk. That's what they want to put it on. And now in real life, like you say, it might be not really that higher, but it's opening eyes saying, hey people, if you have people with hyperthyroidism, there is a higher risk of committing suicide based comparing with the people who do not have it. That's the conclusion.
Other questions or just comments on the paper?
And I offered take-home clinical points.
Please, yes.
If you guys are thinking about who do you need to screen for thyroid conditions, if you a kid with ADHD, think about the big picture. If you have a kid who's had classic symptoms of ADHD, since they were a toddler, then maybe that's not someone you need to worry as much about as opposed to someone that's maybe developed symptoms a little bit later would be concerning for some kind of secondary cause of those ADHD-like symptoms. If you are going to screen, TSH is not an expensive test, and there's one you can order called TSH Reflex that they came out with a couple years ago. They'll just do a TSH, and then if the TSH is abnormal, then they'll run a free T4 on that. And when you're interpreting those, the more labs you order, the more abnormals you're going to get, and not all of them are going to be clinically significant. If you have somebody that has a really low TSH, very suppressed, then make sure you call your endocrinologist and don't displace the referral because we want to see those patients right away, and we need you to pick up the phone and let us know. If you see somebody who's got a TSH that's just slightly below the reference range, please repeat that before you send them our way because chances are you can repeat it the next day, it'll be normal. Unless you guys have anything to add.